Bismillahirrahmanirrahim. Good morning. Hope you are all doing well. Before starting the lecture, I would request you all to please be attentive and concentrate on the lecture material because we cannot write each and everything in the slides. There are so many things that we teach you verbally. So please keep your notebooks and pens ready and note down important points. Make your own notes that would be helpful for you to revise later on. Still, if you feel any kind of confusion, if you don't understand anything, you can come to us. We are always there to help you. Let's start the lecture. Today we are going to discuss cholinergic drugs. We will specially discuss direct acting cholinergic drugs. Learning objectives. At the end of lecture, you should know how to classify direct acting parasympathomimetic drugs. You should know their mechanism of action. You should have knowledge what are the effects of cholinomimetics on major organ system. You should know their clinical uses and toxicities. Yesterday, Dr. Mariam Paracha has beautifully explained you autonomic nervous system, different divisions of autonomic nervous system. She mainly focused on parasympathetic nervous system because in the upcoming lectures we will discuss in details the effect of different drugs on the parasympathetic nervous system. Already, and although Dr. Mariam Paracha has taught you and the receptors of related to parasympathetic nervous system, which are called cholinergic receptors, their location, their effects on the different organ systems, synthesis of acetylcholine, how acetylcholine is released, and how acetylcholine bind to their receptors and show their effects. But before going to direct acting cholinomimetic drugs, which is the topic of today's lecture, I would like to quickly revise the basic things. Autonomic nervous system. So as the name indicates, this is an automatic system. It is unconscious. So this is the motor system. Although it has some sensory fibers, it controls the involuntary actions, motor activities in the body. Autonomic nervous system mainly supplies all the smooth muscles in the body, all the glandular structures in the body, and myocardium, that the cardiac muscles. So in a nutshell, it innervates all the innervated structures in the body except neuromuscular junction and skeletal muscles. Anatomically, we divide autonomic nervous system into three main parts: sympathetic nervous system, parasympathetic nervous system, and enteric nervous system. Sympathetic nervous system, as you all know, that sympathetic nervous system sympathize with us. So whenever we are in stress, we are emotionally disturbed, the autonomic nervous system activate, and a sympathetic nervous system is mainly concerned with fright and flight responses, while the parasympathetic nervous system acts when we are relaxed, when the environment is very comfortable, and we really want to rest and digest. And so our parasympathetic nervous system dominates. The enteric nervous system is located in the GIT and influenced by both sympathetic as well as parasympathetic nervous system. The peripheral nervous system has two divisions: somatic division and autonomic division. The autonomic division, the efferent part, especially the efferent part of autonomic division, is divided into sympathetic and parasympathetic nervous system. As you all know that all the preganglionic fibers, whether they are from sympathetic nervous system or from parasympathetic nervous system, they release a neurotransmitter that is called acetylcholine, while all the postganglionic fibers of parasympathetic nervous system release acetylcholine, and all the postganglionic fibers of sympathetic nervous system release norepinephrine except those supplying the sweat gland, they release acetylcholine. Similarly, the preganglionic fibers of adrenal medulla, they release acetylcholine, while the adrenal medulla release adrenaline, which is directly again you can see directly going to that the preganglionic fibers of parasympathetic nervous system, and they release acetylcholine, and these are parasympathetic preganglionic fibers, they release acetylcholine, while the sympathetic preganglionic fibers, they also release acetylcholine. The preganglionic fibers of the somatic nervous system, they also release acetylcholine, while the postganglionic fibers of parasympathetic nervous system, they release acetylcholine, and then they exerted its effects to various organs. While the postganglionic fibers of sympathetic nervous system, they release norepinephrine and show their effects on different organs. While the parasympathetic postganglionic fibers to the sweat glands, they release acetylcholine. This is the exception. The preganglionic fibers of adrenal medulla, they release acetylcholine, and then adrenal medulla release adrenaline or epinephrine that directly go into the bloodstream. That's why I am repeating again and again. So please remember this thing, that all the preganglionic nerve fibers, whether they are from parasympathetic, sympathetic, or adrenal medulla, they release acetyl. So, sites of acetylcholine, as I have already told you, that all the preganglionic fibers from parasympathetic, sympathetic fibers, and from adrenal medulla, they release acetylcholine. But there are some other sites where acetylcholine is released. Where else acetylcholine is released? These are few exceptions. As I have told you that preganglionic as well as postganglionic parasympathetic fibers release acetylcholine, while preganglionic sympathetic fibers release acetylcholine and the postganglionic sympathetic fibers release norepinephrine. But there are some exceptions. The postganglionic sympathetic fibers to somatic nerves, sweat glands, and piloerector muscles and few blood vessels, they also release acetylcholine. So now onward, this concept should be clear, that all postganglionic parasympathetic nerves release acetylcholine, while all postganglionic sympathetic nerves release noradrenaline, except postganglionic sympathetic nerves that supply sweat glands, piloerector muscles, few blood vessels, and somatic nerves. They release acetylcholine. Clear? Okay. Now, adrenal medulla. I have already told you that preganglionic fibers of adrenal medulla release acetylcholine, while the postganglionic fibers release. Now, autonomic receptor. Beta receptors types and their location is very very important. कल डॉक्टर मरियम पराचा ने भी आपको ये करवाया, मैं अगेन सिर्फ रिपीट ये इसलिए सब करवा रही हूँ ताकि आपको ये अच्छे से याद हो जाए. जब तक आपको रिसेप्टर की लोकेशन, रिसेप्टर की टाइप्स अच्छे से नहीं याद होगी, तब तक आप ड्रग्स के इफ़ेक्ट को नहीं समझ सकोगे. तो इसलिए मेरी आपसे रिक्वेस्ट है कि आप अच्छे से रिसेप्टर की टाइप्स और उनकी लोकेशन को अच्छी तरह से याद करो. फिर आपके लिए ड्रग्स के इफ़ेक्ट्स को याद करना बहुत आसान हो जाएगा. ठीक है. So, autonomic receptors are of two types: cholinergic receptors and adrenergic receptors. Cholinergic receptors are related to parasympathetic nervous system, that's why they are called cholinergic receptors, and while adrenergic receptors are related to sympathetic nervous system. Cholinergic receptors are of two types: muscarinic receptors and nicotinic receptors. Muscarinic receptors are further divided into five types: M1, M2, M3, M4, and M5. Nicotinic receptors are of two types: nicotinic N and nicotinic M. The second type is adrenergic receptors. These receptors are related to sympathetic nervous system. They are further divided into alpha receptor, that is also called alpha adrenergic receptors. The second type is beta adrenoreceptors, and the third one is dopaminergic. Alpha adrenoreceptors are further divided into two types: alpha 1 receptors and alpha 2 receptors. And beta adrenoreceptors are divided into three types: beta 1, beta 2, and beta 3. Let's quickly revise the location of muscarinic and nicotinic receptors and their effect on different organs. As you know, that muscarinic receptors are of three types: M1, M2, and M3. M1 receptors are located in autonomic ganglia and gastric glands. In autonomic ganglia, they cause depolarization, and in gastric glands, they cause release of histamine and increase acid secretion. M1 receptors are GQ protein coupled, and they increase the IP3 and DAG. DAG is diacylglycerol, while IP3 is inositol triphosphate. IP3 is involved in the release of calcium from the intracellular storage. And agonist of M1 receptor is extrotremorin, and antagonist is pyrazipine and terazepam. M2 receptors are basically located in the heart. They are present in the SA node, AV node, atrium. They are also present in the cholinergic nerve endings. In SA node, M2 receptor causes hyperpolarization and they decreases the rate of impulse generation. In AV node, they cause decreased conduction velocity, and atrium they shorten the action potential duration and decreases the contractility. In cholinergic nerve endings, the M2 receptor causes decrease in acetylcholine release. M2 receptors are basically GI protein coupled. They are basically inhibitory proteins. So they are GI protein coupled. They causes opening of potassium channels and they decrease cyclic AMP. Agonist of M2 receptor is methacholine, while antagonist is methotrexate and tryptamine. The third type of muscarinic receptors are called M3 receptors. M3 receptors are basically located in the visceral smooth muscle where they cause contraction of these muscles. They are present in the exocrine gland and they cause increased secretion. They are present in the vascular endothelium where they cause the release of nitric oxide, which is responsible for the vasodilation of vessels. M3 receptors like M1 receptors, they are GQ protein coupled. They also increase IP3 and DAG. The agonist of M3 receptors are bethanical, while their antagonist is cholinergic receptors are called nicotinic receptors. Nicotinic receptors are of two types, NM and NN. NM receptors are located in the neuromuscular junction where they cause depolarization of the muscle end plate and they cause contraction of the skeletal muscles. NM are basically ion channels. They causes opening of the cations, sodium and potassium channels. They causes opening of cations, sodium potassium channels. Agonist of NM is nicotine, while antagonists are tuberculin. The second type of nicotinic receptors are called NN. NN receptors are basically located in the autonomic ganglia. They are present in the adrenal medulla and CNS. In the autonomic ganglia, they cause depolarization. In adrenal medulla, they cause release of catecholamines, and in CNS, they cause either excitation or inhibition. They are also ion channels. They also cause opening of cations, sodium, potassium, and calcium channels. Agonists of NN receptors are nicotine, and antagonists are hexamethonium. Cholinomimetics or parasympathomimetics are classified into three groups: choline esters, alkaloids, and synthetic drugs. Choline esters include acetylcholine, that is the prototype drug, and the other drugs are included in this group are methacholine, carbachol, and buthanicol. Alkaloids include muscarine, pilocarpine, and acetylcholine. Synthetic drugs include simimeline and varenicline. Acetylcholine. Acetylcholine is a prototype cholinomimetic agent. Acetylcholine is basically quaternary ammonium compound. It is rapidly hydrolyzed by acetylcholine esterase enzyme. That's why acetylcholine is not used therapeutically because it has a very short half-life. Pharmacological actions of acetylcholine. Acetylcholine has both muscarinic action as well as the muscarinic action of acetylcholine. Let's start with the heart. As you all know that muscarinic M2 receptors are located in the heart. M2 receptors are present in the SA node, AV node, and in atrium. So acetylcholine causes vasodilation of the coronary vessel, so it decreases the blood pressure. Acetylcholine has negative chronotropic effect on heart. Negative chronotropy means heart rate. Negative chronotropy means it decreases the heart rate. So acetylcholine decreases the heart rate and has negative chronotropic effect. Acetylcholine has negative inotropic effect. Inotropy means force of contraction. So acetylcholine decreases the contractile force of myocardium. So acetylcholine has negative inotropic effect on the heart. Acetylcholine has negative dromotropic effect. Dromotropy means conduction velocity. So acetylcholine decreases the conduction velocity, AV conduction. So that's why acetylcholine causes negative dromotropic
The
effect.
mechanism behind these effects
is that the acetylcholine activates the muscarinic M2 receptors in the heart. It causes the opening of potassium channels. Because of opening of the potassium channels, there is increased influx of potassium in SA node, AV node, Purkinje cells, and in the ventricular muscle cells. This increased influx of potassium causes hyperpolarization and reduces the duration of action potential. At the same time, acetylcholine decreases the inward calcium current in the heart cell, and as you all know that calcium is important or necessary for the muscular contraction. So when inward calcium influx is reduced, the force of contraction is also reduced.
If we summarize the effect of
acetylcholine on the heart, we can say that acetylcholine acts on the muscarinic M2 receptors in the heart, and because muscarinic receptors are located in the SA node, so by depressing the SA node, it decreases the heart rate. Muscarinic M2 receptors are also located in the AV node, so by depressing AV node, it decreases the conduction velocity, and M2 receptors are also present in the atrial and ventricular muscles, so it causes decrease in the atrial and ventricular
causes vasodilation of the blood vessels by activation of M3 receptors. When the M3 receptors are stimulated by acetylcholine, they causes release of endothelial drive releasing factor from the endothelium, which in return causes production of nitric oxide. This nitric oxide stimulates the enzyme guanylyl cyclase, which converts GTP into cyclic GMP. This cyclic GMP stimulates the enzyme protein kinase G, which causes phosphorylation of myosin light chain kinase. Due to phosphorylation of myosin light chain kinase, there is no phosphorylation of myosin light chain heads. When the myosin light chain heads are not phosphorylated, there is no interaction between the actin and myosin, which is important or necessary or compulsory for the muscle contraction. So when the actin myosin heads are not phosphorylated, there is no interaction between the actin and myosin, so no contraction occur and blood vessels relax and vasodilation occur. This vasodilation is responsible for the fall in the blood pressure. So the net effect of the acetylcholine on the heart rate depends upon the concentration of agonist in the heart and the blood vessel. If we give the agonist in small doses, reflex tachycardia occur due to
starting the
compensatory
effect of
mechanism.
acetylcholine on the respiratory system, I would request you all to please note down the question for today's assignment. Question is, please write down the location of muscarinic and nicotinic receptors and their effects on different organs. Thank you. So as you all know that muscarinic M3 receptors are located in the bronchi. So acetylcholine by stimulation of M3 receptors in the bronchi causes contraction of bronchial smooth muscles. That's why bronchoconstriction or bronchospasm occur. As you all know that parasympathetic nervous system causes increased glandular secretions, increase the activity of all glandular structure in the body. So by increases the glandular secretions, it increases the secretions of glands in the tracheobronchial tree, so increased tracheobronchial secretions occur. In the GIT, acetylcholine stimulates the muscarinic M1 and M3 receptors that are located in the GIT. By the stimulation of M1 and M3 receptors, acetylcholine causes increased peristaltic activity in the GIT. It causes increased gut muscle tone and it relaxes the sphincter. At the same time, acetylcholine by stimulation of M1 and M3 receptors increases the activity of salivary and gastric glands. So these glands are strongly stimulated, so GIT secretions increase, and the net effect is the patient got diarrhea. M3 receptors are located in the detrusor muscles of the bladder and in the trigone sphincter. So stimulation of M3 receptor by the acetylcholine causes contraction of detrusor muscle of the bladder, and at the same time it causes relaxation of the trigonal sphincter. and the net result in the patient got maturation. I have already told you that parasympathetic system causes increase secretion of all the glands. It increases the glandular activity throughout the body. So by stimulation of muscarinic receptors by the acetylcholine causes increased secretion of salivary glands, lacrimal glands, bronchial glands, gastric glands, and thermoregulatory sweat glands. Muscarinic M3 receptors are located in the circular muscles of the iris, which is also called sphincter pupillae. So, stimulation of the M3 receptors by the acetylcholine causes contraction of sphincter pupillae, result in the meiosis. Because M3 receptor by stimulation of acetylcholine causes increased secretion of lacrimal glands, so increased lacrimation occur. Due to contraction of the ciliary muscles, maximum accommodation of the eye occur. This is called cyclospasm. Because acetylcholine causes improved drainage of the aqueous humor, so there is fall in the intraocular pressure, and this is helpful in treatment of glaucoma. Nicotinic actions of acetylcholine. Acetylcholine acts on the autonomic ganglia. In higher doses, it stimulates both types of ganglia, sympathetic as well as parasympathetic. While in cardiovascular system, the sympathetic stimulation dominate. Because of stimulation of sympathetic nervous system, the blood vessel constrict. Due to vasoconstriction of the blood vessel, the blood pressure increases. Sympathetic stimulation or sympathetic predominance causes tachycardia, which means increased heart rate, but it alternate with the bradycardia when the vagal discharge occur. While in SA node, the parasympathetic nervous system predominate. In the gut, parasympathetic control dominate, and this result in increased motility and increased secretion in the GIT. In skeletal muscles, initially acetylcholine produces twitching and fasciculations. This is followed by prolonged depolarization of the neuromuscular junction and paralysis of muscles occur. In this slide, we can summarize the nicotinic actions of acetylcholine. In autonomic ganglia, both sympathetic and parasympathetic system are stimulated. In cardiovascular system, the sympathetic system predominate. That's why vasoconstriction of the blood vessel occur and blood pressure increases. And because of the predominance of the sympathetic nervous system, tachycardia occur, but it will alternate with bradycardia when the vagal discharge occur. In SA node, parasympathetic stimulation is predominant. That's why in SA node, due to parasympathetic stimulation, heart rate decreases and bradycardia occur. In gut, our parasympathetic system predominant. That's why in GIT there is increased motility and increased gastric gland secretions. In skeletal muscles, initially acetylcholine causes twitching and fasciculation, but in long term, acetylcholine causes depolarization of the neuromuscular junction and paralysis occur. In CNS, acetylcholine does not penetrate because it cannot cross the blood-brain barrier. So no of acetylcholine on muscarinic receptors. Acetylcholine stimulate the muscarinic M3 receptors in the eye and causes contraction of pupil, meiosis occur. It causes contraction of the ciliary muscles for the near vision and accommodation occur. It increases the secretions of lacrimal gland. It improves the flow of or drainage of aqueous humor. So that's why intraocular pressure falls, and this is helpful for the treatment of glaucoma. Stimulation of M3 receptors in the respiratory system. There is smooth muscle contraction in the tracheobronchial tree and bronchospasm occur. M3 stimulation by the acetylcholine increases the tracheobronchial secretions. M3 and M1 receptors are located in the GIT, which causes contraction of the gut muscles. So, increased peristalsis occur, and there is relaxation of the sphincters. Diarrhea may occur. M3 muscarinic receptor stimulation in the urinary bladder causes contraction of the detrusor muscle and relaxation of the sphincters, and maturation occur. And as you all know that M3 muscarinic receptor stimulation in all the glands increases the secretion of all glands throughout the body.
So secretory glands, salivary glands, lacrimal, bronchial, gastric, pancreatic, gallbladder, intestinal, sweat glands, all glandular secretions are increased in the body. Stimulation of M2 receptors in the heart causes bradycardia. It decreases the force of contraction and decreases the cardiac output. So acetylcholine, by the stimulation of M2 receptors in the heart, exert its negative inotropic, negative chronotropic and negative dromotropic effect. Acetylcholine causes vasodilation in the blood vessel by the stimulation of M3 muscarinic receptors. The acetylcholine basically activates the phosphatidylinositol system, IP3 को ज़्यादा करती है, that causes a rise in increased intracellular calcium that results in the formation of nitric oxide from arginine in the endothelial cells, and that leads to vasodilation. In CNS, it affects the extrapyramidal activity and affects the memory. Adverse effects of acetylcholine. Acetylcholine causes diarrhea because in GIT it increases the peristalsis, it increases the secretion of gastric glands, and it relaxes the sphincter, so it causes diarrhea. It may cause nausea. It causes diaphoresis, which means excessive sweating due to increased secretions of the sweat glands. It causes contraction of the ciliary muscle, so meiosis occur, and it causes urinary urgency. Another drug from the same group, cholinergic esters, it is methanicol. It is also a direct acting parasympathomimetic drug. It mainly stimulates the muscarinic receptors, mainly M3 receptor. It has no effect on the nicotinic receptors. It has wide margin of safety, and its side effects are completely reversed by atropine. Bethanicol is preferred in the treatment of post-operative urinary retention because bethanicol relaxes the trigonal sphincter, so it is very helpful in relieving the post-operative urinary retention that occur most probably after operation. Bethanicol is also important in the treatment of non-obstructive paralytic ileus because in paralytic ileus there are impaired digestive movements. So bethanicol improves the peristaltic activity in the gut lumen, so it is helpful in treating the paralytic ileus but non-obstructive type. Third drug from the same group is carbachol. It has both muscarinic and nicotinic action. Carbachol is carbamic acid ester. It is resistant to hydrolysis by acetylcholine esterase enzyme, so it is not hydrolyzed by this enzyme because acetylcholine esterase enzyme basically hydrolyzes the acetylcholine, so this enzyme cannot hydrolyze the carbachol because it is resistant to that enzyme. It is effective in chronic open angle glaucoma and if patient do not respond with the pilocarpine. Here is the comparison between different drugs of the same group: acetylcholine, methacholine, carbachol and bethanicol, and they are all choline esters. Acetylcholine is rapidly hydrolyzed by acetylcholine esterase enzyme, that's why it has a very short half-life and it is not used therapeutically. Methacholine, carbachol and bethanicol, the remaining three drugs, they are resistant to acetylcholine esterase enzyme and they are not hydrolyzed by acetylcholine esterase enzyme. Acetylcholine, methacholine and carbachol, these three drugs have both muscarinic and nicotinic action, while bethanicol has only muscarinic action and no nicotinic action. Acetylcholine is non-selective and it has no therapeutic use because it is rapidly hydrolyzed by acetylcholine esterase enzyme. Methacholine is selectively used for cardiovascular disorder. It is used in the treatment of paroxysmal supraventricular tachycardia. Carbachol is used selectively in the GIT and bladder disorder. Carbachol we mainly use in the treatment of post-operative non-obstructive urinary retention, neurogenic bladder, bladder atony, and congenital megacolon. Bethanicol is also selective for GIT and bladder disorder, and it has the same clinical indication as carbachol. Next group of direct acting cholinomimetic drugs is cholinomimetic alkaloids, and this group includes pilocarpine, muscarine and ericoline. Alkaloids are basically drugs that we obtain from plants. So alkaloids are drugs that have plant origin. Pilocarpine is a cholinomimetic drug. It is an alkaloid that is obtained from Pilocarpus plant. It is a tertiary amine and it crosses the blood-brain barrier. It has predominant muscarinic actions. Pilocarpine is mainly used in the treatment of glaucoma. Especially pilocarpine eye drops are used in the chronic open angle and acute congestive glaucoma. Pilocarpine is used to break the adhesion between the iris and the lens. It is also used to treat xerostomia. The xerostomia is basically dry mouth resulting from absent or decreased saliva flow. Xerostomia, it's not a disease, but it may be a symptom of various medical conditions, or it may be a side effect of radiation to head and neck surgery. Pilocarpine we use to treat xerostomia after head and neck surgery or radiation therapy. Cevimeline, it is a synthetic direct acting cholinomimetic drug. Cevimeline is used to treat dry mouth after radiation of head and neck. It is also used in Sjogren's syndrome. Sjogren's syndrome, which is characterized by dry eye, dry mouth, and arthritis. Varenicline, it is also a synthetic and direct acting cholinomimetic drug. Varenicline is a basically partial agonist at nicotinic receptors in the brain, because it reduces the craving and withdrawal effects of nicotine. So we use this drug as an aid to smoking cessation. Adverse effects of cevimeline and varenicline are they causes increased salivation, they may cause nausea, vomiting, excessive sweating, they may cause bronchospasm, decreased heart rate, diarrhea, and cutaneous vasodilation, and that's why flushing may occur. Muscarine is an cholinergic alkaloid. Active ingredient of muscarine is poisonous mushroom, which is called Muscaria amanita. Short duration type of mushroom poisoning may produce symptoms of nausea, vomiting, and diarrhea. Cholinomimetic drugs should be contraindicated in the following condition. Cholinomimetic drugs should be avoided in patients with asthma and COPD because these drugs causes bronchospasm. They should be avoided in urinary and GIT obstruction. These drugs should be contraindicated in patients with acid peptic disease because they increase the acid secretions, and because these drugs causes vasodilation and causes fall in blood pressure, so these drugs should be avoided in patient with hypotension, and these drugs should be contraindicated in patient with hyperthyroidism. So this is the end of today's lecture. Students, kindly note down the question for today's assignment. Question number 2 is write down the adverse effects of acetylcholine and write down the clinical indications of carbachol. Thank you.